Hello, everyone, and welcome to the January 2018 Underserved Population Learning Action Network webinar. Today we have our own Misty Cabbage presenting Actions to Improve Health Literacy, and Misty has presented this content around the country, and it's been really well received, so we're very fortunate that she's agreed to present it here today so that we can all learn from it. For those of you that I haven't met, my name is Cindy Sun, and I, like Misty, I'm an HHQI RN Project Coordinator. Now, before we get started, we'd like to review a few of the basic webinar features. All the phone lines are currently muted. We request that you enter all of your comments and questions in the chat window on the right-hand side of your screen and use the drop-down box to include all participants, or you can use the Q&A box as well. If these are not options for you at this time, if you look at the upper right-hand side of your screen, you can click on each of the icons to make them become populated and available for use. If you're listening to this as a recorded webinar, we'd like to encourage you to send all of your questions to HHQI info, which is hhqi@qualityinsights.org. Now, a bit later in the presentation, you're going to be asked to take a few minutes to critique a document for health literacy. The link to that document, if you'd like to print it ahead of time, it can be found either in the chat window or on the web page where you register for this course. It's on the Underserved Population tab on the HHQI website, and it's under today's webinar. You'll see the link for resources towards the bottom of the page. Now, if it's not convenient for you to print at this time, you'll have time later in the presentation. Now, before we get started, we wanted to offer you a brain teaser. Just take a quick 10 seconds and work out this problem. Did you come up with the answer of 4? If not, remember that we always start with the multiplication first in any type. Then we move to the subtraction, the addition, and we come up with the answer of 4. Doesn't really pertain to today's webinar, but we really wanted to kind of get your brain in the idea of learning. So with today's objectives, there is no math. I will just say that upon completion, we really hope that you're going to be able to identify at least 3 red flags that indicate that your patient may have health literacy issues. We also hope that you'll explain how to check written patient materials for readability levels, and we hope that you'll be able to describe at least one method to assess a patient's understanding of the education and instructions that we as clinicians provide. Today's course is it's approved for 1.5 hours of continuing education by the Alabama State Nurses Association, and they are an accredited approver of the American Nurses Credentialing Center's Commission on Accreditation, or the ANCC. We'll give you some instructions a little later in the webinar as to how to proceed and obtain your certificate for the 1.5 hours of nursing today. Now, before turning the presentation over to Misty, we wanted to take a few minutes to review a few of the stats and definitions to make sure that we're all on the same page when it comes to health literacy. The patient protection, as you can see here, the Patient Protection and Affordable Care Act defines health literacy as the degree to which an individual has the capacity to obtain, communicate, process, and understand basic health information and services to make appropriate health care decisions. A few other stats to think about is that 88% of all U.S. adults have literacy issues. 36% of U.S. adults have limited health literacy. And 65 years and older, that's the group that makes up the largest portion of our patient population. They're more likely than any other group to have only basic health literacy skills. As you're thinking about your patients, think about this. 80% of the patients will forget what their providers and clinicians say, and nearly 50% of what the patients remembered, it's incorrect. 42% of the patients could not understand directions for taking medications on an empty stomach. 43% of the patients didn't understand the rights and responsibilities, that section in the Medicaid application. 60% of the patients did not understand a standard informed consent. As you're working with your patients, there are red flags that we all as clinicians need to think about that will give us some understanding that maybe the person is being non-adherent because of health literacy. So these are health literacy red flags. Maybe your patient is missing appointments frequently. Maybe they're not completing their registration forms accurately. Maybe they're non-adherent with medication. Maybe they're unable to name the medications or explain the purpose of the dosing, or they're identifying the pills by looking at them. They're not reading the label. Maybe they're unable to give coherent sequential history. Maybe your patient is asking fewer questions. And maybe they're lacking of follow-through on their tests and their referrals. Now, before we turn this over to Misty, just want you to consider which ones of you may have had some of these red flags. And Misty's going to talk to us and describe what we as clinicians can do to better assist our patients in improving their health literacy. So, Misty, I'll turn it over to you.
So much, Cindy. Thank you so much. And thanks for everyone joining us today. I hope that you're going to learn a lot, and a lot of this is very simple and common sense, but we have to think about applying it on a daily basis as we work with our patients. So some of the areas of health literacy that we're going to cover today include measurement, navigation, verbal and written communication, and evaluation. There are more, and we're not going to be able to cover all the areas, but these are the areas we're going to look at some of the barriers and then some tools and resources that could help address those barriers. Sorry, let me get it started here. There we go. So before we move into measurement and give you the tools, which I will be listing for you, I want to go back to some of the statistics that Cindy brought up initially. She brought up that 88% of all adults in the U.S. have some type of health literacy issues. That's almost the entire population. Also, adults 65 and older are affected even more. So it is essential that we have a good understanding as leaders, clinicians, caring for patients, and even as family members as we work with our families to really have a better understanding of health literacy and who would have a health literacy issue. Sorry about that. And it doesn't matter education level. People that have a master's degree still can have health literacy issues. The healthcare environment is very complicated, but there are some tools that you can use to measure health literacy. So I'm going to just give you a couple of the better tools that I think are pretty good. The first one is short assessment of health literacy, and it's 18 test words that you ask the patient to tell you what they are, just to state what the word is. There is also, let me get my, sorry. A little trouble getting it. There we go. The rapid assessments of adult literacy in medicine, and it's now only 7 terms, and I put that on the slide for you. It used to be 66 instrument test. Can you imagine sitting during a visit or an encounter and asking a patient to read 66 terms back to you? As a patient, I would be feel very indignant in doing that, and I can't imagine the time. But what's exciting is that studies have shown that the 7 test item, it has excellent agreement with the 66 instrument. So you would provide a list of these words to the patient, ask them to tell you what the word is. They don't have to describe what it means. They don't have to do anything else but tell you the word behavior, menopause, anemia, jaundice. That's all they do. And the instructions give you how long you wait or if you skip over it. Now, these 2 tools, and I'm going to show you another one on the next slide, there is not a perfect tool, but these are all evidence-based. Because with health literacy, as it was in the definition, it's readability, it's comprehension, it's including numeracy. And so reading these 7 terms has nothing to do with numbers at all, but it is a way that if you need to validate a person has health literacy, you can use that simple tool. Now, the next tool I really like, it is the, sorry, there we go. The newest vital sign, and it came out probably, I don't know, 8 years ago or more. And it's basically you would hand a patient a food label, and they give you the food label here, and it is an ice cream label is what it is. And we have down in your slides, they're all hyperlinked to the resources, and we have an English and Spanish label that we have that are larger, so it would be easy for patients to read. And then what you do is you give them the label, and then you ask specifically 6 questions to the patient. And I'll give you an example of what the first one is. If you eat the entire container, how many calories will you eat? So the patient has to look at this and say, well, there's 250 calories per serving. I have to go up and see that there's 4 servings per container. So that's multiply it, 1,000 calories if I ate the entire container. Well, does that sound a little complicated? And would we ask patients to do something like that? We do it every day. We ask patients to read labels, to lower their sodium, count carbs. We ask them to look at their medications, take half doses, decide about insulin doses on sliding scales. So numeracy is a very important part of health literacy. Now, then they'll ask some other questions, and then actually the last 2 questions are related that you tell them to pretend like they have an allergy to the following items: penicillin, peanuts, latex gloves, and bee stings. Even if they don't, just pretend. And then you ask, is it safe for you to eat this ice cream? So now they have to look at the ingredients, and they have to decide if this is safe for them to eat, but they have a peanut allergy, and so that could be a problem. So again, is this important for our patients that we serve? Yes. We have more patients that are developing food allergies later in life, and they need to be able to read the labels. So this is another really good tool, but it doesn't really look at their readability level. It does some by reading what's on the ice cream label, but it could be a really good tool for you. Now the next, but my big point that I want to really provide you is that you should, oh, I'm so sorry, I hit, and let me go back again. Sorry. Having a little trouble with my slides not wanting to move here. Let me get caught up here. I'm having some technical literacy issues here today. All right, so my tip to you is you should just assume that every patient has health literacy issues until they prove differently. As I mentioned before, it does not matter about their education level. It doesn't matter that they're a clinician either. I can tell you this summer when I had some surgery, I had a hard time figuring out my pain medication schedule when the doctor said, no, just take Tylenol and you can take more than what's ordered on the label. Well, I could only think as a patient when you're in that having pain and trying to manage that I had to write things down with hashtags to keep track of what I was taking. I couldn't think, well, you know, take 2 tablets every 3 hours and that will give you, you know, what you need and still be under the amount the doctor told you you could take above the prescription level. I couldn't do that. So, you know, it doesn't matter. We really should assume that everyone is. But is it important to do a health literacy assessment? In many cases, yes. Maybe your organization is trying to validate that and you want to be doing the score. But I'll tell you another really good time that this could be valuable is if you're seeing a patient that's an Advantage or an HMO and you're getting your visits that are being pre-approved. And they give you limited number of visits, but you're finding you have to really simplify your education and having to do reinforcement. And so those 8 visits are not going to get you where you need to go. But if I did a measurement using an evidence-based test and validate, I'm really struggling with being able to teach the patient on these items, and here's her health literacy score, you're going to have some evidence behind you that should help you get some additional visits. So now let's move into navigation. Now, there are a variety of people that are on the call today from different settings. Some are from home health, and some are from physician offices and other settings. So think about navigating. Our patients don't come into home health agencies, but don't we send patients out to doctors' offices or to hospitals for tests? So we need to think as clinicians, where we're sending our patients and how can we help them be able to locate and find the area that they need to go to. We need to look at the automated phone systems. We all utilize those. That patients get lost within those numbers. How fast is it they're speaking? How many levels do they have to go? Look at process changes. I can give you a quick example. My dad's PCP had a change in the office practice of how you do labs after your visit. Well, we ended up, now I'm a health professional, sat for 45 minutes extra in the waiting room because they changed the process and we didn't know that, and that we should have checked out first, then got labs. Health history paperwork, new physician appointments, they send you a packet in the mail. You're to fill it out. If you go to a physician's office, look at the new patients coming in. Many say, oh, I forgot the paperwork. The others bring it empty or only filled out the first paragraph or two and then got lost and didn't fill anything else out. So we as healthcare professionals can help patients fill that out in advance, knowing they're going to be going to a specialist. Insurance papers, assistance, medical assistance, advanced care planning paperwork, all of those are complex. They don't understand. And as well as transportation. Physical transportation is difficult for our elderly patients. If you live in rural areas, most of the time there isn't even services available. But even in inner cities, many of your buses have had to make cuts, so the stops are now further away, perhaps from the high-rise or the apartment where the patient lives. Cabs and jitney drivers and Ubers don't go into high-risk areas. So there's many reasons that can impact their medical care because of transportation issues. Now, here are some tips with navigation is to walk through your facilities. If you're a facility, the patient's going to come in, walk through with a health literacy lens. And I really hope you start doing this everywhere you go. I can't help it, and it drives me nuts sometimes. But it's eye-opening to see and see how they're addressing the issues or how you could address the issues. And an example is I had to go for some testing a few years back at a large system hospital in Pittsburgh, and my husband was with me. We get at the hospital, and they hand us a little map to show us where to go. She circles because we have to cross a bridge into another hospital building to get to where my testing's going to be. No problem. We were able to follow it. No issue. I still don't know how my husband found the cafeteria on his own, but that's another side story. But I did also note that the hospital representative was helping people, older people, that definitely were going to have issues. That little map was not going to do it. They actually had volunteers or staff that actually walked them to the department that they needed to go to. So they had to think out their physical building and how to work that. Some have, colored lines to take them wherever, but it still is confusing. You have to look at your signage. And if I was in home health helping a patient to go for a test, I may want to not even worry about getting them to the right department, but my instructions might be there is a front desk as soon as you walk in the main doors. Ask for assistance there and tell them to ask for someone to help them get to where they need to go. So we need to think outside of just seeing that patient. We also need to provide as much information to other providers, such as if we're sending a patient to the emergency department, I need to send a summary of the meds, what's going on. And I want to identify that they might have some health literacy issues or try to address any problems that might occur. I can do a brief update for that PCP visit to provide them as much information that's going to save that patient in trying to relay correct information. We have a few resources. The Navigating the Healthcare Systems synopsis are just two little examples that you could use for team or staff meetings to introduce that concept of navigation. One is a patient's going to the physician office for the first time, and the other is doing a home health admission and with all the paperwork involved. And an additional tool is the patient health record. Now, if we were live right now, I'd ask for you to put your hands up if you've ever used a patient health record. So you're welcome to put your hands up if you'd like, but I hope that you have. They're a wonderful, simple paper tool to help carry information from one provider to another provider or setting to setting. They usually include diagnoses, surgeries, medications, allergies, tests, results, as well as your advanced directives, contacts, and your medical team. I will tell you, I have used one for over 12 years with my father. And he used to be able to go by himself to doctor's visits. I just call, remind him what time to go. He would take this with him. I'd have questions written down inside that he would have asked, and he would handle that. They would call me with what the changes would be since I live several hours away. But now I have been going to the appointments with him, and we were just at one the other day. So I make sure we take that with us everywhere we go. So he is in a habit of taking it. Plus, I don't know what dates his surgeries were. I can't tell you all of his particular medicines were ordered by which doctor. So I rely on that health record. But we constantly provide the same information to all the providers. It was an excellent resource when we had to start care within the VA system, because basically I handed it to the nurse that was entering all his information, and he was able to get everything he needed in a very easy format to be able to put into his system. So, you know, these are just simple documents and they're easy to use. Now, medical appointment reminders. If Cindy mentioned with the red flags early on, one of the red flags is missing appointments. Well, we also know that having a follow-up appointment after a hospitalization, usually 7 days is a window that's used, is a strategy, an evidence-based strategy to reduce hospitalizations. But what happens when they come home from the hospital? If the hospital even made the appointment for them, and some hospital systems do that, that is part of their quality plan to improve reducing hospitalizations. Even if their family member made it, where are they putting that or their next visit? When we go to a physician's, most of the time you get a summary sheet, and the next appointment's kind of like a business card. It's real small on maybe one of the last pages. Well, patients come home from the hospital and their doctor's appointments, and they put the papers that they're given, usually in this infamous stack of papers, that they don't know what to do. They're overwhelmed, so we just stack it there. We may not throw it away. We might have years' worth of papers in that stack. So we have to think about how we can help remind the patient for those visits. Most offices do that automated phone call. I appreciate that immensely. But for people that have health literacy, they get lost with that message. If they pick up, it says, we're reminding you of your appointment, et cetera, et cetera. Press 1 if you're confirming your appointment. Press 2 if you're going to cancel the appointment. Well, they get confused, so they might just hang up and not go to the appointment because they're not sure if they canceled their appointment. The auto messaging is usually pretty fast. So if you have auto messaging, even for patients calling in, how fast is it? Is there enough time for patients to pick the response? Is it easy for them to go back to the home menu so they could start over? As a home care professional, I might want to call the doctor's office and say, you know, Mrs. Smith really struggles with those reminders. Can you mark her chart to do a physical call to her? Yeah, some do postcards, but most of the time it's all automated today. But for those patients that really need that phone call, it's well worth having that dialogue with the team. Another simple tool is remember that little follow-up appointments on that little tiny business card. Well, this is a half-sheet paper. It's called a doctor appointment reminder. Very simple. Place to write the date, the time, the name of the doctor, the type of the doctor. That's important. Heart doctor, diabetic or sugar doctor, whatever that patient's going to connect that name with. And then there's a little place for notes where I could put the transportation, the that you'll be picked up at 8 a.m. It's going to cost $2. You know, I could write that there so the patient is ready. They're not getting frustrated before they get to the doctor's office, and I can increase the chance that that patient's going to keep that appointment. So my questions for this visit is a really good tool, and there's a link that'll take you to the ARC site for it. And sometimes your patient health records include those, because we want the patient to be active and engaged into their care. That's the only way we're going to do and really work with disease management. So the patient's got questions, just like you and I might have, but as soon as that practitioner, that doorknob turns and it opens and the doctor or the nurse practitioner comes in the door, everything flies out of their head. So writing down questions is something we teach patients, but let's give them a tool or some way to write it down. I would give the paper for the patient to take with them or the family member, maybe put a call out the day before to remind them to take that paper with them. I also might want to go ahead and fax or securely email that over to the doctor's office ahead of time with my summary, just because I want that patient and practitioner to really take advantage of that moment in asking and talking about the questions the patient actually has. So these are some tools to help with that. Now we're going to move into verbal communication barriers. So just like this webinar has been, it's all a monologue. I've done all the talking. Isn't that kind of how we do health education? Tell. Patient might respond a little bit, usually with a yes or no, and usually it's with what they think we want to hear. We talk real fast. I got 3 more visits to make today. I've got to finish this visit quickly. So our talk speed starts to increase. We cover way too many topics at one time, but we're only allowed X number of visits, or we have a short period of time to visit with this patient, but we have to think about those things. We use medical jargon and scientific terminology often, and the information is often forgotten quickly, and Cindy gave you some statistics on that at the beginning. So these are problems with verbal communication. So I want you to find your chat button. If you have a box, if you haven't opened it, go up to the right corner and you'll see a little blue box that says chat, and get it open. And we want you to type in here. I'm going to be putting up one word at a time, and it's a word we use all the time. And these are actually from a study to show that these words are often used in healthcare education and conversation. And I want you to write a better word. Okay, so let's start with the first one. Diagnosis. So what are some better words for diagnosis? And go ahead and throw them into chat. Give those a second to start coming up. Whoops, lost them. All right, there we go. Problem.
And also just want to remind everybody that to make sure you're in the chat window where all participants can see it and you're not in the Q&A box. If you're in the Q&A, unfortunately, not everyone can see it. And you all have some good ones.
Well, go ahead, Cindy. Give us a couple that they said in the Q&A.
Well, we also had a couple problems in Q&A. We had disease, we have illness, we have sickness.
Good. Okay, great. Okay, and everybody can now find the chat button and make sure it's set to send to all participants too. It's usually defaulted there, but sometimes it's not. How about immunization? Let's do the better words for immunization. All right. I'm going to make sure that I'm seeing everything. Oops. All right. Sorry, I just make sure that I was saying shots. Thank you. Flu shot, pneumonia shot. Great, that's it. So just try to, we'll try the next one. Diabetes. So what other words could we use for diabetes? Go ahead and put those into chat.
It doesn't look like all participants is an option for attendees. So they're either sending it to all attendees or all panelists. If they're sending it to all attendees, the panelists can't see it, and they're sending it to all panelists, and the attendees can't see it.
I see. Okay,
Yeah.
well, we'll just keep going here at this point.
We can go ahead and use the Q&A. I think everybody should be able to see those.
Okay, I'm seeing, now I'm seeing sugar.
Now I'm seeing some.
They figured it out. Great. Thanks, guys. Sometimes the defaults mess us up more into things. Okay, let's try another one here. Recognize. Recognize. What's a better word for recognize?
Misty, I'll tell you what we're getting in the Q&A box, if you'd like.
Go for it.
We're getting notice, a couple different understand. We've got a see.
Wonderful. Okay, great. So and then we have annually. We tell patients that they should have the flu shot annually. What are better words for annually? There we go. Every year, yearly. Great. And how about eliminate medication? We want you to eliminate this medication. Stop. Thanks, Susan. Great. Thanks. Mark's got stop too. Stop taking. Very good. Okay. And the last one is examine. We want to examine. I'm going to examine your feet. Look at. Thanks, Susan. Look for.
Marcy.
Very good.
Marcy in the Q&A is with check. And we have look at from Kathy.
Great. Okay. All right. So you get the point. But are these not words that we use often? So you have to think about the medical jargon. All right. Now let's move into some tips and resources for verbal communication. And I will tell you that some additional resources will be included in the written communication because they kind of do both. So we'll cover some more a little bit later. First is to cover the most important information or actions first. And actually, I'm going to take it a step further. I like to bookend the most important information. So I start my visit with what I think is the most important, and I end my visit with the most important, so that that patient knows that I have spent time talking about it. It's the first thing we talked about, the last thing we talked about. But if they start to tune out, if I at least covered it first, they can perhaps retain that information. Keep it to 3 to 5 key points. Use plain language, and I'll talk about that more. Engage the patient and family into the discussion, because the more that we do the talking or only ask questions that are yes, no, the patient is not going to to be engaged at all. So we really want to engage them. And I'm going to introduce you, if you aren't familiar with the OARS model, on the next slide, and we'll talk about teach back, and we're going to do some activities with that. Now, the OARS model is open-ended questions, and what open-ended questions are to make sure that you're not asking yes or no. Use words like how, why, tell me more about. You should avoid the word why and use that for special occurrences, because patients could become defensive with the word, well, why did you not take your cholesterol medicine? Instead, I should ask, tell me more about your cholesterol medicine and how you take your medicine, or, ask why, you think that the medicine is not, why you're not taking the medicine at this time. I'm sorry, I just said not to use the word why, but how are you taking? Show me how you take your medicine. So open-ended questions allow that patient to be part of the dialogue. And then when we affirm, what we're doing is we're demonstrating that we're paying attention. We can do this verbally by using words such as, that we're listening, let them know that we're listening by, I can see, oh, that's a really great idea. Even will work. It lets them know that I'm listening to what they said. Doesn't mean I agree with what they're saying. Head nodding, eye-to-eye contact, not being in the, our eyes totally in the computer, looking at that patient, listening to that patient. So that's an important part of the process. And then reflect The reflect is where we can evaluate any misunderstanding. So it gives me a chance to either restate what the patient has said or even add a little bit more because I think that's what they're saying. So I can say, like, you're not sure how to reduce your blood pressure or how to lower your blood pressure. So I'm going to say something back to the patient, and then they're going to correct me, and then we can continue along that line. So that's reflection. And summarizing or summarization is restating what was said before, and it's ideal for before you move on to a new topic. So I might want to summarize about the medications before I move into their wound. It's also a great way to end a visit, to summarize what we've talked about, hit that really important key points, and then making sure I use some open-ended questions at the end to make sure the patient gets a chance to correct me or ask for more information. So I could say, like, here's what I heard you say. Tell me if I missed something. Or you can say, what other questions do you have for me about your medications today? So it's just to make sure it's a good way to engage that patient. If you want to know a little more about OARS, you can Google it. We've also have a link at the bottom to take you to our university where we have a course on basics for chronic disease management, and it does go into OARS Model in more detail. All right, and teach back. Now, if we were on the room again, I'd be having you put your hands up, but it's been fortunate that we continue year after year to see more organizations, more clinicians using teach back, but we still don't have, it's not universal still. So teach back is actually a health literacy tool. It came out of this work, and it's to check if the message sent was received. But it isn't testing the patient, it's really testing the clinician. It's because I might need to restate this and try a different way to get it across to the patient. I either was too high of a level, I didn't make sense. A really great example, many years ago when my dad needed to have open heart surgery and have a valve replacement. The doctor started talking and you saw the glazed look at him. But the doctor stopped and he said, tell me what you did in your life. You know, what kind of jobs did you do? And then what he did, he said, well, you understand plumbing then because you do home plumbing at your own house. And then he turned the conversation into pipes and valves, and my dad totally got it. He still today can tell you about his valves and his surgery because of referencing it related to plumbing. So it is testing you and it is creating you as clinicians to be more creative to finding the way to best tell the patient the information. So here's some examples. I've given you a lot of information on your medication today. Would you mind saying it back to me so to make sure that I know that I was clear? I know your daughter's going to ask tonight about the visit and what we talked about. What are you going to tell her? And the other keywords is tell me about this medication, or tell me about your sugar, or show me how you take your medicine, show me how you do whatever the item is that we want them to do. So those are really keywords for doing teach back. Okay, now Misty Dyke is going to put a link for you within in the chat window. So find your chat window. If it's not open, again, look at the top right corner and click the chat. It's going to be a link for you to go watch a 1-minute video. So we want you to, I'm going to be quiet for a minute and allow you to watch the video, and here's your homework or your assignment while you're watching it. I want you to think about teach back. I want you to think about how this video impacts teach back and how do you feel about it. So go ahead and grab the link that Misty put into chat. You should be able to just click on it, and then I'm going to time it out, and we'll be back in like a minute and 10 seconds. And if you're having trouble, you can always watch it later, but it is in your slides and it is linked, but hopefully you can click there. everyone should be finishing up the video. We've given you the link, so we have seen, some responses coming in. It's funny, but isn't it true? This is what can happen. I love this one, patient education, epic fail. But we need humor a lot of times in our education because it then makes a real point for what we do. So I can't look at an inhaler ever, and I've been using this video for probably 7 or 8 years, without thinking about the Dr. House video. And sometimes the link will go away, but they repost it on YouTube, so you can always find it, but we've provided it for you. But that is exactly how some patients could take it. Some other tools for you with TeachBack. In our HHQI underserved population BPIP, I've even given you the pages and some tools. The IHI is open short. It is just a minute and a half on what is TeachBack. A great thing to do in staff meetings or team meetings to introduce the topic and or to refresh it. It's something that we always sometimes have to be reminded we need to do all the time. Now, there are some other health literacy strategies that are similar to TeachBack or really are TeachBack in a different way. And this is easy. Oh, before we go further, I'm sorry. I wanted to go back up and chat. There was a great comment earlier that I wanted to get back to from Richard. TeachBack may need to be done by the patient representative. Often the individual has family members with them for that very reason. And that is so true. And especially, I tell friends and family members, anytime they're going for test results, especially if it's a biopsy that could be cancerous, even if they're, have college degrees or awake, that are alert and oriented, that you always need to have someone else to be there with you. So take advantage of that. The health literacy strategy chunk, check, chunk. It's real simple. It's easy to remember. You do a chunk of your information, just a little piece of it. You check. You do a little TeachBack to make sure they got it. And then you chunk another piece and do another check. So that's an easy thing. You don't chunk, check, chunk. It's very simple. The next strategy is ask, tell, ask. And what this is a really a good point with engaging patients is you should ask permission first to share information. So I might want to say, is it okay, Mr. Smith, if we would talk about your high blood pressure today, and asking permission to share. The other way you can look at ask is ask them what they already know. So why should I start with the very basics? If I ask them to tell me what they know about their sugar, I'm going to learn the things that they do know. I'm going to learn the things that they have incorrect information, and I'm going to figure out all those omissions that they didn't bring up that I know where I can start with. It will save you a lot of time. Tell. Tell simply and concisely 1 or 2 points. That's all you really want to work with. And then ask. You can ask them what they think about the information, or you can ask a TeachBack question. Can you tell me or show me how you're going to take this medicine we just talked about? So it's an ask, tell, ask. So we have a resource from another IHI open short video on YouTube, a minute and a half, a great way to introduce that. It's a very simple concept. Then there is the Ask Me 3. This is through the National Patient Safety Foundation. These are 3 questions. If we could get our patients to go to the practitioners and even in our encounters, like for home health, if this is what the patient and their caregivers ask and address during their visits, it's going to cover what's important to the patient. What is my main problem? Asking that. Why do I need to do that? And why is it important for me to do that? We will make better improvement with disease management if we get patients to be comfortable and able to ask that. And you can start with Ask Me 3 has some great resources and scripts, little reminders what to do, and lots of videos that you can watch too. Okay, now we're going to move into written communication tips. Some of these are first the barriers, I guess, too much information. And we have some really great patient tools that sometimes they're many pages. We have some workbooks at HHQI, but we've been very cautious of how many pages we put in them. But I have downloaded, especially when I'm researching defined tools for agencies and organizations to use, I found workbooks that are 50 to 90 some pages for patients. There's no way that that's so overwhelming. Paragraphs in multiple pages, it's not focused, it's all over about lots of different things about maybe the one disease, but it's all over the page. Reading levels too high, medical jargon or scientific words like we looked at before. Patients get overwhelmed and get lost, usually within that first paragraph. And it's very confusing. The information's confusing. So I'm going to show you just quickly. We have them sign consents all the time. So this could be a piece of a consent that says, I authorize blank to release to blank the medical records of blank. Well, as a healthcare professional, I have to think about, where do I put my name? What name goes here? How are our patients really going to understand? Most of the time, they just sign things and they don't understand. But they're supposed to, if we broke this down into more sentences or put cues underneath the line. So I authorize patient's or representative's name to release, and then to release the medical records. I left the word representative on here as an example. And sometimes legally you can't reduce the words down, but smaller words, thank you, Richard, and also large print. So here you could still play with, if you legally can change the word to representatives, then that's what you would do to a small word that's comfortable. And then you could finish out name of the patient and to the name of the person or the office. And if they're going to be releasing the information to your office, don't have a line. Fill that in with your name, even if you handwrite that in or have that as part of your form, because that's one less thing for that patient to have to figure out, or their caregiver. Okay, so here's some tips, and you want to provide that most important information first, kind of like that first bookend we talked about with communicating. So here we want to put that first. If I lose that patient not far down into the patient sheet, at least the main point has been made. List the number of messages that you're giving in one document, no more than 3 to 4, and really probably error on the smaller number. Give them what they need to know and what they need to do. Information, we have a lot of information we want to convey to the patient, and really it would be nice if we had a USB drive we could just plug into their head to give them. But there's really need to know, the absolutely critical information. There's the nice to know, and for some patients that's going to be interesting and meaningful for them. And then there's all the other stuff, the kind of the fluff, but it's interesting to us, but we really have to look with people with health literacy, which is the majority of our patients, and do the needs to know. We want to give them one message at a time. We want to use short, long lists, bulleted list, 3 to 7 bullets, try to keep it as simple in the least amount of words, even with the bullets. State it in terms of actions, using an active voice. Clean, whatever it is. Use something that is an action, and we want to also do it from a positive standpoint. So do this, not don't do this. We want even our written words, every single written word is so important. And tell the patient what they're going to gain from reading or looking at this tool that you're giving them, or a resource, so that they have an understanding what they should get from it. Writing patient tools and is very difficult. I know for a lot of years, it's the answer to every problem, or if we're working on hospitalizations, everybody wants to do a patient tool. And they don't realize how difficult it is. You really have to spend time and making sure that it is small, using bulleted. Thanks, Rachel, with some short bulleted statements. It does take time and practice, and it's going to take some testing time as well. So obviously choosing your words carefully, short, keep it conversational, not being preachy, also not being very formal. Offer small practical steps. cutting sodium out of a diet, reducing salt, using that word salt for making sure the patient understands, but maybe giving them a couple steps they could get started with. And providing examples is great. If I read an example, it gives me an idea what we're talking about. Patients are the same way. Limit that medical jargon. Be consistent with your words. If I'm using the word medications, and sometimes that is the best word that you need to use for your patient tool, then use medications everywhere. Don't use medications, meds, drugs. You use the same word all the way through. Avoid unnecessary abbreviations and acronyms. Not everybody understands those, especially when we look at other cultures that we're working with. And don't use statistics. Instead of using 50%, you could use the word half if that's a valuable point to make in your tool or your information sheet. And avoid using symbols. Symbols are not standard. They're not universal, especially across cultures. Now, grade level. Most of the time, you're going to aim for a 5th to 6th grade level. You might live in an area you know that's even lower, so you could do that. And I get this question often, if we have patients that are high, that have college level, they would be turned off by me giving them a document that's 5th to 6th grade level. I go back to that statistic. 88% of people have some type of health literacy. It might not be reading as the issue, but I would start with that tool. So if I'm going to do a QAPI plan and I'm going to implement this tool, I would still probably introduce it even to patients that have higher level, because I'm going to make sure that they don't have health literacy issues before I give them something higher level. I can always say, now I know this is a simple tool, but gets the main points across. Would you be interested in something that's a little higher level? I can give you, some things to read. I could give you some websites that would be really good to supplement this. And that's a way you can address it, but it's better to start low and work your way up. Font size. What is recommended is 12 to 14, but I rarely even use 12. I do 13 as a low point when I'm trying to get things to be on the one page, but 14 or higher is even better. Font style. Now this is interesting because it used to be they recommended that serif fonts, and I gave you some examples of what serif fonts are better. But actually some research came out in the last year or two that says that might not really make a difference. What a serif font is it has, they're called hands and feet. And I have an arrow by the hand at the top, and then you can see at the bottom of the S there's like the line that ends it. And they used to believe that that helps patient being able to read and moving to the next letter. But that's not necessarily correct now. Well, it really depends upon your population. So we say find a font that seems to work best, test it out with patients, some of your family members, some patients, to see if they're able to read it. Is it easy on their eyes? And then once you find, you might have to try a couple different ones to see which is easier, then stick with what you find works best. Bullets, we've talked about that numerous times. And bold type. Everyone, all these words are really important, so I want to bold them. Be careful with how many words, because otherwise it's going to blur together. Limit the italics or underlining, because that is very difficult for older eyes to read. And avoid all caps. That's as though you're shouting, those letters come close together and it's hard for patients to read those. Now, dark letters are the best on light colored paper. So all of us know, remember that pile of paper that everything gets put into at the patient's home when they come home from the hospital or whatever we give them? Well, so I'm going to put that on fluorescent pink so it stands out and I can tell them to get that. That's actually very hard for them to read. Dark black is the best color. Now you can use, you can have some colors with pictures and things, but actually for the font, black is even better than dark blue. There's been studies that show that even dark blue is not as good as black. And light colored paper is good. If you want it to stand out, maybe think about a light pastel. Appropriate punctuation. So with bullets, I don't usually put punctuations when I'm doing presentations like this, but if I'm doing it on a patient document, I want to put a period because I need that patient to know that was the end of that thought. Move to the next. And if I'm using action words, then it's going to make a little more sense. But I want them to know I finished a thought, or commas, whatever is appropriate. Subtitles or headers will really break up a document. It'll kind of put that into, oh, I can see we're going to talk about medicine here. I can see we're going to talk about how to test your sugar in this next section. But you can also put things in boxes and sections. If you get a really good document and it's something that you're currently using and it doesn't have boxes or sections, you could still take a marker and make a box around the area you want them to read and reinforce what between your visits. This is the important thing I want you to look at. Box it out. Their eyes will be drawn to that box. And white space is important. That's all the white space around it. A lot of times we're trying to cram as much information. Okay, you know, Misty said I should try to make it one page if I can. So I'm going to go down to 12, maybe 11 font, and I'm going to squish as much in here as I can get it so then go over to 2 pages. You lose that white space around it. That's where the eyes have a chance to rest and to be able to move to the next section. They get lost, overwhelmed, and they quit reading. So that's important. It would be better to have a 2-page tool with the correct font size and more white space. And when you use pictures, make sure they're meaningful and culturally appropriate. So this example that I put on this slide, I could have had it on, it could have been on a medication worksheet that I'm going to give to a patient. Well, they're going to see this as, oh, could even be my aide. It doesn't even have to be the nurse, but there's somebody, my healthcare provider of some sort, is talking with a patient and his family. I miss that there's a pill in the middle of of her hand. So if I was going to use this if I want to be talking about pills, I want either a hand with a pill in it that would be large enough to see, or a pill bottle that makes sense, the patient can understand. So make sure that don't make pictures to make it pretty. It needs to be able to complement the text. Otherwise, the patient's going to say, but I don't understand why this is important, and they may miss the whole concept of what the information was. Okay, we're going to do a reading activity. Now find your chat box again. I'm going to give you instructions, and then Cindy's going to come in and kind of get some of your comments. You don't have to print this document off. You can look at it on your screen, just pull it up. We are also not making fun of the document. This is a CDC document. We picked this specifically because it looked good. It's a 2-page document, but there are some really good points about this document, and it looked health literate. So what we want you to do is to take a quick look. We're not going to spend a lot of time on this. Just look at page 1. Take a look and see what you see wrong, and we want you to put that into chat. Or the Q&A, but if you can find the chat box for all participants, that would be great. And then we're going to go over a few of those.
And if it's easier for you guys to put it into the Q&A box, that's fine too. We just want to be able to see the responses. Give it another 30 seconds, and then we'll start reading off some of these responses to make sure everybody can hear each other's. Misty, we already have some really good responses. Artery wall, what is that? And then, as Burl mentions, it doesn't say what high is. There's no definition of high. Barbara has mentioned no bullets. The red print is hard to read. It's small print. Mark has mentioned it's too much info. Uses words like factors and increase. There's too much information on one sheet. Systolic and diastolic needs to be explained, says Catherine. Dense paragraphs of information from Laura. Too much of the background, increased BP rather than bulleting the risk factors. Pictures do not indicate the information is about blood pressure. That was from Laura. Mark mentions it's not 5th or 6th grade reading level, irrelevant pictures. I think you guys are picking up on this nicely. And the meaning of ethnicity, it's vague, not enough white space, the type is too small. These are all great comments. Jargon, lots of words, too many words, too complex. If you know a little about high blood pressure, it is too dense in facts. 1 in 3 adults is hard to understand. Not straight to the point. My goodness, you guys have nailed this one, Misty.
Great.
Good group.
Great, thanks. And I love the last one that's sitting there too. What does a barbell have to do with blood pressure? Absolutely.
I just read that one.
Yeah.
I love that, Jennifer. Nice job.
Great. Great, thanks. So you get it. I mean, you get it. But it really was a really good tool. When we looked at the tool, it's a nice tool. There are some really good things about the tool, and we normally, if we were doing this live, would talk about some of the good things. But there are some really nice things there. But there's ways. So the thing is what I'd like you to, don't worry about going back and looking at this tool again. I want you to go pick something that you give out to your patients on a regular basis, something that you think is pretty good even, and go through it after what you've learned today. And take a look at how can we tweak it? How can we make it more health literate? Start with one tool at a time, because a lot of your tools are going to be much higher level, but we want you to start making some progress somewhere. So I'm going to show you this study that was done, that they gave patients a medication bottle, and the instructions were, and they spelled it out pretty clearly, take 2 tablets by mouth twice a day. So what they did is they asked patients, do they think they understood the instructions? And then they asked them to show me how many pills, take out of the bottle, how many pills that you think you need to take in one day. So that's what they did with this study. Now, I know the slide is going to be a little busy, so follow me with your eyes. Go to the bottom into the x-axis. Look at the patient literacy levels. They're divided by low, marginal, and adequate. Now we can take a look at the yellow bars. That's where the patient said that they understood the instructions, what they thought was correct, that they thought they understood the instructions. And you can see, the further down with the literacy level, they didn't quite understand it, think that they understood it as well. But look at the green, which is the demonstrated. It is half for the low literacy level, and even those that had adequate health literacy still were not demonstrating it correctly all the time. So there is a lot of room for improving how medicines are written out. We know pharmacies send them home with very tiny, but you can ask for larger print. Now, I don't have another slide that went with this study. I'm going to tell you that they changed the label to say, instead of take 2 tablets by mouth twice daily, they changed it to take 1 tablet in the morning and 1 at 5 p.m. Much more specific. And I will tell you that the green bars, what they demonstrated, were significantly different. Right now, what you're looking at, for the low literacy, it was 35% with the original. With the more specific, it went to 83%. Were able to demonstrate it correctly. Well, medications are really critical. And when I read this study, I said, but when I look at the original, take 2 tablets by mouth twice a day. I personally would have taken 2 tablets in the morning and 2 tablets at the second time of the day. I would have taken 4 tablets. But actually what they wanted the patient to take was 1 tablet in the morning and 1 at 5 p.m. Well, it was confusing. So that patient would have been taking double the dose that they should have been taking. So it's a really, I think, a busy slide, but I think it's really relevant to medications. So now what about readability assessments? So there are formulas to calculate what the reading levels and grade levels are. No longer do you have to sit. It's based mostly upon syllables and length of sentences. And I used to read a document and literally tap my feet to count polysyllables, 3 or more syllables in a word. And then there used to be a formula to use. But now, and they also make it by U.S. school grades too. There are many free tools, and I've given you a link that'll take there, but I've listed 3 that I think are important. The Flesch-Kincaids, both the grade level and reading ease. I'm going to show you that, and I'm going to tell you why that one's used the most often. And then the simple measures of gobbledygook, the SMOG index is one that is used worldwide, and you can get those free tools that are available. The reason the Flesch-Kincaid is important is it's in Word. So if you're working in Word and developing your template for your patient tool, you can do to find out what the readability level is, but it's not automatically set. You have to go into your Word options. It depends upon the Word version you have, but here's some instructions of how to find it, or at least the right kind of words to be looking for. And you just have to turn it on. And then it's under proofing, so it's going to go with your spell check is where it's going to go. And I'm going to show you what the results will look like. So I would type up my document, and I'm going to tell you, don't even run a readability initially. I type up what I want to do. I go in and play with those polysyllables. Go look at those words that are big. Go look for those medical jargons. Fix everything you think you can fix. Put things in bullets. Don't worry about putting graphics in. Just make it very basic. Then run a spell check. And then at the end of your spell check, at the bottom, you'll get the readability. And you'll see your Flesch reading ease. And I'm going to give you, it doesn't give you there, but I'm giving you their ease guidelines on this slide. So what we're looking at in the document that I ran to get the slide, it's showing at 79.5. That's in the easy, fairly easy range. I'm actually pretty happy with that. That's not too bad. And then I can look down to my grade level, and it's a 5.4. That's a U.S. grade level. So I'm within that 5th to 6th grade level. So I'm actually not I would be pretty happy with that. I'd look at it again. I'd have a colleague or two look at it, and then I would test it with some patients to see, you know, how able they were able to do that. The SMOG is basically, it's an index by the number of syllables, and there are free online tools. You just take your text, drop it in, and it will give you that. It's going to be counting it a little differently. Since we're doing tools that we provide to organizations across the nation, I always run them twice. I run them in the Flesch-Kincaid till I get something I like real well, and I'll run them into SMOG. Sometimes it might run a little higher because the way they're counting it, but I usually can get it somewhere between the 5th to 6th. Now, sometimes you're not going to be able to do that. And I recently had proofed a document for an organization, and because of certain words, infection, immunizations, we were able to change a little bit, but there's some words that they were unable to break down any lower, and that word was used often. So, you know, it came up as a 9th grade reading level, but they worked as much as they could to get it down to except for that one word or 2 words that were the problem. So sometimes you just have to do that lower, but if you start with one of your patient tools and just test it, I'm going to tell you most of the time it's going to be 10th or higher than 12th grade level. I'm giving you lots of resources in the for written communication, lots of links and page numbers. The other aspect that you have to look at is translations. We have communities of patients throughout that you're serving. What needs to be translated for the patients, because an English tool is not going to be very relevant if you are working with a population of Spanish and Spanish is their primary language. So here's some tips and resources. Use culturally appropriate pictures. You know, even if you find things out, CDC has lots of tools and resources, and a lot of times they will offer it in a version that's for people that are Spanish speaking or have that heritage, perhaps for African American. So you can go and find tools that are adjusted for that, or make sure you pick pictures. Although we have a hard time sometimes, Misty Dyke, our communication specialist, has a hard time finding those for us to be able to purchase sometimes. Select your translator carefully. If you're fortunate enough to have a healthcare professional that is fluent in that language, they could possibly be, but because you're giving this out to a lot of patients, you want to be careful. So like we had to hire and use a certified medical translation organization. Make sure they're certified in medical, because my son is fluent and has a degree in Spanish, and he hated it every time I used to say to him before we did this, and it's like, can you translate this for me? He's like, but our words are not the same when you talk about medicine and you talk conversational or reading. So don't do that. You know, you really need to have someone that is versed in medical transcription. And what we did is we narrowed it down to 2 organizations. We took one simple one-page document, we sent it out to both and paid for those to be done. Then I did have my son review to show me the nuances between the 2. But you can also do that with Google Translators type thing. What's the differences? How close were they? And then pick an organization you want to work with. Don't use those free online translation like Bing Translate or Google Translate to be your translation for your documents purely. Now, I do use those for checking. Like sometimes we get something back, and maybe I want to tweak something little. We updated our English form, and it's just something very small. I will go in and put it in English, have it translated in Spanish. Then I'll take that copy of the Spanish version that the online tool's giving me, and then I'll go into a different tool. So I may have started in Google. Then I'll go to Bing, and I'll put the Spanish in and have it translated back to English. And so I might make some small moderations that way by doing that double translation or reverse translation, but otherwise we do send things out. We're doing some documents now that had significant changes. We have to have those retranslated. We do a lot of our patient tools, I will tell you, for HHQI that are key tools, not all of our tools, but we do translate those in Spanish usually. We also do a lot of our tools in Chinese, Vietnamese, and Russian, because those are the higher percentage based upon the U.S. populations that will need to have tools translated. So those are some tips. Let's get to this. So here's the summary. We've covered a lot of information today, but think about these couple points. You really need to focus on the must know, must do. Utilize those teach-backs or similar strategies. We talked about chunk and check, ask, tell, ask. Those are important because I can do a really good job teaching, but if I don't check it and evaluate myself, change it up, then that patient's not going to have that information and know what to do with it. Provide clearly written health-appropriate materials. And I really encourage and hope that you all start to imbue any encounter in the healthcare environment with that literacy lens, that health literacy lens. I can't help walking into an emergency room and looking at signage, looking at what they're telling patients, the handouts they're giving out, all of those things. Would the patients be overwhelmed with what they're being told, what they're being given written? So I do hope that you all will develop some good health literacy lenses. So we're going to move to the Q&As, and if you have questions, please put them in chat or the Q&A box, and Cindy's going to help facilitate those for us.
Thanks, Misty. I don't know if any of you have heard this content before, but I've probably heard it 3 times, and every single time I learn more. It's just, this is something, especially as older clinicians, that we weren't exposed to in school. So I hope that you're able to apply some of what Misty has taught us today and shown us those examples. I definitely have my spell check set for my reading level as soon as I learned how to do that. So let me take advantage of anything that anyone has to offer with that. Okay, Misty, we did have one question, and it's a specific question about the health literacy assessment tool that you mentioned. Is that available in the public domain?
Yes, all of those tools, and they're linked from the slides, so make sure you download the slides from our website, and it'll take you to the tools. I think they're all on the ARC website, but yes, they're in the public domain. Good question.
Okay, that's good to know. What other questions do you guys have? We want to make sure that we get to them all. And I will take a minute and mention that if you are watching this as a webinar, as an archived recorded webinar, you can contact us with questions later to HHQI@qualityinsights.org because we want to be able to address all of your questions. So with that, while you all are maybe coming up with your questions, we'll go ahead and move on. And we'll come back to questions, so don't hesitate. If you have them, go ahead and put them into the Q&A box, and we'll get to, like I said, as many as we can. We want to remind everybody that the next Underserved Population or UP networking event will be scheduled on April 19th from 2 to 3 p.m. Eastern. If you're not already subscribed to the HHQI mailing list, you may want to do that so that you can be among the first to know when the details are available of each of these webinars. Continuing education. As I promised, here are the steps if you are interested in obtaining the CE certificate for today's session. Now, I'm going to tell you in advance, this looks complex. If you have not done it before, trust me, it's simple. Just take the slide with you when you go to the university. So the first thing you want to do is go to HHQI University and either register or log in. If you think you already have an account, but you can't quite remember, just contact us at HHQI@qualityinsights.org. Once you're logged in, click on the Actions to Improve Health Literacy course that is found in the Underserved Population course catalog. That seems to be the step that a lot of people miss. Once you've clicked on this course, click on the Enroll. It's under the Apple icon, and then click on My Account. Once you're there, click the Go icon next to the course in the View column, and then click the Go icon in the Action column next to Lesson 1. After completing the evaluation, and this will take you a very short period of time, you can print off your certificate from the My Account area in the HHQI University. You just click on the My Account. That'll be on the black toolbar going across the top, and your certificate will be under the My Certificates area, and it's listed on the left-hand side of your column. I said that wrong, on the left-hand column on the side of your screen. So we'll pause again to see if there are any additional questions before logging off for today. Well, seeing no additional questions, if you do have any that we have missed or if you have any in the future, we do encourage you to contact us directly or contact us through HHQI@qualityinsights.org. And if you were not able to watch the teach-back video during the session today, highly encourage you to watch that, if nothing else, just so that you can have a quick giggle pretty much for the rest of your career every time you think about teach-back. With that, we would like to thank Misty for all of this great information. We'd like to thank all of you for joining us. Please feel free to contact us at any time with anything we can do to help you. And we want to thank you for joining us today. Have a great day, everyone. Bye-bye.